Top Med Talk.
Hi, it's Monty Mythen here, Editor-in-Chief of Top Med Talk, back with you live from Anaesthesia 2019. I've just been interviewing Paul Wischmeyer, fantastic interview, who's going to be giving one of the orations, this Samuel Thompson Rowling oration later on today about caring. But I've been joined by a regular on Top Med Talk. I think he's been with us once. Is that right? Makes it a regular. Tim Cook. Twice you've been on, Tim. Yeah, from Bath, one of our national leaders in various different roles. So I think before we spoke quite a lot about airways, which is one of his specialist areas. But today we're going to talk a little bit about emergency laparotomy. So Tim, welcome back. What else has been happening in your life? Any other new roles or...
No. Same old.
Same old?
So I'm still only known for one thing, which is Mr. Knapp.
Mr. Knapp. What's a Knapp?
National Audit Project.
Okay.
So the college, and occasionally with other partners, runs national audit projects, which are usually 3 or 4 year projects looking at major complications of anaesthesia across the country, and they are... in a way, a great, although we're looking at complications of anaesthesia, they're a great advert for Anaesthesia UK. Yes. Because we're able to capture data from across the NHS, usually 300 hospitals, 3 million anaesthetics over a 1 year period, and look at the fallout in a particular area. So NAP3, we looked at major complications, life-changing complications of central neuraxial block. NAP4 was major airway complications, including an intensive care and ED. NAP5 awareness, NAP6 allergy. And NAP7 starting next year will be perioperative arrest, which we have to start by defining.
Now, almost every time I talk to you in recent years, Tim, it's been, is this your last nap?
This is the Steve Redgrave question, yeah. Shoot me if you see me next to a new nap. And consistently I've said for the last 3 years that I want out. But I've decided that NAP7 is such an interesting topic that I think if the college will have me, I'll stay.
Good, excellent. That's great news for
probably
us.
Outside my decision.
Now, there's naps and snaps, aren't there? But you're nap man, not snap man.
Correct. Yeah. So I do the long haul job, not the short haul job. So the Sprint National Anaesthesia Project, so the A is anaesthesia for that, Sprint National Anaesthesia Projects are shorter projects which usually last for a week instead of a year in terms of data collection.
Yes.
And again, focus on one particular area of investigation. So SNAP-1 looked at patient-reported outcome measures, which was the first time that had been looked at in a decent cohort of patients. I think we looked at 20,000 patients. I was very peripherally involved in that. I've been a collector of data, certainly, as we all have.
Of which I think Thirst came out as the number one.
Correct. Yes.
Yeah. Not pain anymore, and not PON-V. It was Thirst had gone to the top of that.
Thirst at the top. Anxiety, pain, and nausea and vomiting. I think in that order.
Yeah. There we go. And we have and the more recent one, SNAP-2, related to critical care provision. Is that right? And the engagement is the envy of the world, I would suggest. It's almost 100%
it's
engagement.
It's as near as you could
the whole
split
country.
Hairs universal. So, and that is why it is. I consider anaesthesia to be a miracle of science, and I consider the naps and the snaps to be a miracle of engagement in terms of they are voluntary to take part in. But for instance, in the snaps and the naps, pretty much 100% of UK hospitals. So that's 4 nations take part in. For NAP 5, we had 5 nations because we had Ireland taking part as well, and it's a huge credit to anaesthetists or anaesthesiologists in Ireland taking part in these projects.
And recently, I think SNAP-2 has been replicated or done in parallel in Australia and New Zealand.
That's correct.
I believe. Yeah, fantastic. Yet to penetrate the USA, I think, where it's harder to necessarily get the whole country to play along at once.
Yeah, there have been discussions, often in countries that have universal health provision, such as Canada. New Zealand and Australia have been interested in the naps and snaps.
But they're a big network. Paul, aren't you part of a big network in the Carolinas? And I mean, you do network, don't you?
Yeah, we do have the Carolina Collaborative.
That's bigger than England, probably.
Maybe.
Yeah.
Close.
Well, landmass.
Landmass it is. Yeah.
So Paul Wischmeyer, welcome back. So from Duke University Medical Center, critical care physician specializing in nutrition, but also giving the oration later on about your own lifelong experiences as a patient and reminding us that we should care for people. Now, you were just sharing with me, just while we were grabbing Tim, about some nutritional issues related to ethnicity, I think, in the United States of America. Can you play that back to us? Because I think it's going to overlap, because we're going to get onto emergency laparotomy.
You were mentioning acute care surgery, which is something we're acutely interested as well. We work very closely. Our ICU colleagues that are surgeons are also acute care surgeons.
Because you do surgical.
So I do surgical intensive care, and then we see many acute care surgery patients, of course. And the NIH, the National Institutes of Health, has come out with a call for proposals on surgical disparities. So why is it that African American patients have far worse outcomes from surgery in the USA, for instance? I don't know how this data translates to other nations, but from surgery, from trauma, and from acute care surgery, why is that? And it's not unique to all minorities, say in the U.S. Hispanic patients and Asian patients actually do better or the same as a Caucasian patient, but there's something unique about an African-American patient or low SES, low social economic status patient, that seems to portend bad outcomes. And one of our hypotheses, one of the things we're going to submit, is actually African-American patients uniquely have the highest rates, substantially highest rates of malnutrition when they're admitted to the hospital and subdiagnosed objectively in our big HCUP database, which is a big national database. And so, interestingly, Hispanic populations, other minority populations, have the lowest rates of malnutrition. So it's not unique to ethnicity or perhaps even to broad SES, although SES does drive it down. We wonder if there's something unique about, in this case, the African-American culture, but also perhaps social economic status, or genetics or something else environmentally that creates this high risk of what we call malnutrition. And is that a mechanistic driver for why surgical outcomes and trauma outcomes, ARDS outcomes even, are worse?
And we have to emphasize to people, I think, that these are people who may well, when you eyeball them, look what you'd call well-nourished, or even possibly they've eaten a bit too much.
Or overnourished.
Yeah, exactly.
But yet are likely sarcopenic. So now we're doing this by CT scan and ultrasound. We actually are objectively defining what we call malnutrition now with low muscle mass and low muscle quality by CT scan and by ultrasound.
Large, what appear to be overtly obese people, but very many of those are malnourished from the point of view of getting the right stuff into their body.
Correct.
Tim, any thoughts on that from the UK perspective? And then we'll get...
about sarcopenia. No, it sounds very sensible. I've always been impressed by the link between that and frailty.
Yes.
In terms of the so X-ray diagnosis of frailty based on muscle bulk. And it's a scan of the. I'm just trying to remember the muscle.
You've been doing the CT scans.
Yeah, at L3. Yeah. By convenience, really, but we traditionally have looked at L3. The organs are sort of out of the way. It's easy to see the muscle there. We're looking at other areas as well. Now doing it by ultrasound, which is applicable to a pre-op clinic or a peri-op optimization clinic.
Get a cross-section of the fillet steak.
Yeah, literally. And you can do this now by ultrasound as well at the bedside in a surgical setting, an acute care setting.
We did 2 podcasts about that recently from John Whittle and one of your visiting...
Yeah,
exactly.
Your own Mullinger.
Who was telling us about the time he spent in freezer cabinets in supermarkets.
Yes.
ultrasounding the meat quality.
And cadavers, too.
Yeah, and telling us about
pictures of the cross-section of legs.
Kobe beef phenomenon, where you may have what looks a nice big piece of meat, but when you get the ultrasound on it, it's got fat streaks all through it, and therefore it's not actually great muscle.
Yeah.
So I like that objective methodology, because I see the Canadian classification of frailty which is a sort of functional status, and when patients come into our ITU, I'll see variation by about 3 different levels depending on who's filling it in and how far you've gone with the history. And I think that's one of the problems. So I think that something objective would be a huge benefit.
Because these scans, as far as I understood it, not only can you get you can quantify size, and I think people are moving on from the size story because Olympic cyclists have tiny, scrawny little muscles that work great.
Right.
Into the sort of quality issue.
So fat infiltration, and the fat infiltration of the muscle actually is just as predictive. There's ICU publications out of the Netherlands showing the same, that fat infiltration and muscle quality is just as predictive as muscle mass. And so muscle quality may be very much so. And we're able to do that by ultrasound as well now.
Bedside ultrasound.
We're just validating that now.
Great stuff.
Yeah.
So, Tim, we dragged you over to talk about emergency laparotomy. I think we've all been a little bit shocked. We've discussed it in a number of podcasts here about one of the big national trials that came out recently, a large step wedge cluster randomized trial, trying to look at quality improvement in emergency laparotomy, and the sort of gasp from the audience when the trial results were released appeared to be no difference at all. And then the discussion was it overcomplicated and was it under-resourced? Whereas a lot of this work presented by Carol Peden came out of your institution, you and your buddies there, where you did something and made a huge difference and then networked it. What's going on?
I can't answer exactly what's going on, but I can tell you the Bath story.
Yeah.
So we've had an interest in emergency laparotomy for probably almost 20 years. As a registrar, I looked at mortality after emergency, did an audit a local audit of mortality after emergency surgery, both orthopaedic and gastrointestinal, and tried to publish it and was almost banned from applying for jobs in Bath when the surgeons found out what I was trying to publish.
Yeah.
But we've moved on from that, and I now get on with them very well. But we, about 7 or 8 years ago, when Carol Peden, who's now in the States, was a consultant in Bath, we instituted a bundle of care under her direction, which is very similar to many of the bundles that are now used in emergency laparotomy and a lot of what is now in NELA as well, the National Emergency Laparotomy Audit. And we were about to introduce that 6-point bundle, which I can talk you through the bundle if you want to. And we then joined 4 other hospitals, and the 4 hospitals did the bundle together. We did a before and after study that was called ELP-QUIC, and that was published probably back, as I say, you've just dragged me over, so I haven't got the dates quite right, but I think that was probably published in about 2013, 14.
ELPQUIC.
Correct.
Yeah.
Correct.
And it's PubMed, you can find
Correct,
that.
yes.
You can find the paper.
Yes.
Yeah.
And our mortality, so we implemented the bundle. We had reasonably good implementation of the elements of the bundle. And our mortality during the study, which was a six-month study, fell a few percentage points from a mortality of about 14% across the board to around about 10%. But interestingly enough, in the next 6 months, it then fell to 5%.
Wow.
So that was roughly half or less than half of the national average at that point.
Yeah, literally.
And we thought that we were quite good, actually. It's one of the things we focused on in Bath. We were very pleased with ourselves. We were certainly slightly self-congratulatory. And a few years went by, and then we were asked to join the Emergency Laparotomy Collaborative, which was, as it sounds like, was a collaborative of hospitals across the south of England and into Wales, really a horizontal line almost from below the M4, for those people that know that, so perhaps the bottom fifth of England and South Wales. And we thought, well, we've probably got a few things we can tell these guys. And we then asked to look at our data again, and we found that not only was our compliance with what was essentially the same bundle much worse, but our mortality had risen to actually higher than it was before, around about 14%, 12 to 14%, which was the same as the national average. And we were embarrassed by this and set to engage with the bundle again and to relaunch it. And we were able to launch that, and within the next 6 to 9 months, our compliance with the bundle increased, the 6 elements of the bundle increased, and once again our mortality came down to 5 to 7%. So again, halved.
Compliance is everything.
So I think it's very interesting that EPOC is implementing a not dissimilar bundle, and at least the principles are not dramatically different. On a local scale, we've done it twice now, with pretty much identical results. And what we're now focusing in is not just the quality improvement element, but the aspect of maintaining the quality gains once you've achieved them, and changing not just behaviour, but changing culture so that they're embedded. And I think when you talk about ERAS, you talk about it being you on your best day,
exactly,
and making making what is your best day a normal day.
Normal day. Compliance, and then there's stickability, or whatever you want to call it, is the
Yeah.
two recurring themes in all of these quality improvement type of programs. Is can you get because it looks as though in the big study that was done, the EPOC study, that compliance didn't really change, and the stickability wasn't there either. Whereas I think what I'm hearing from you, just like the enhanced recovery success stories, is high levels of compliance, and then to get it to stick and make it normal.
That's right, and I mean, we're a small DGH, and I think one of the advantages of being
a small
district general hospital. So,
about 400 to 600 beds for that.
Yeah, we've got 600 beds. Yeah. We serve a population of about 500,000. Yeah. We've got an intensive care, which is a mixed level 2 and level 3 unit, which has a maximum of 14 beds. So we're a medium-sized hospital, and emergency laparotomy is one of the more high mortality types of surgery that we do. We don't do a lot of the tertiary specialist work, and so it's something we're able to focus on, and that perhaps has been an advantage for us in being able to focus on change.
Paul, do you have some questions about that?
Yeah, what are the interventions?
They may not be exactly in the right order. I'll probably go backwards. So we admit all our emergency laparotomies to intensive care, or to critical care. The vast majority is level 2. So in NELA, the recommendation is that patients who have a predicted mortality above 5...
NELA is our National Emergency Laparotomy Audit, which again has got pretty much 100% compliance. So we know about every emergency laparotomy real-time, live in the country.
Amazing.
Let me try and do it antegrade rather than retrograde. So there's early review by senior clinician.
Yep.
Okay. And as part of that review, there is early detection of risk of sepsis and early administration of antibiotics when indicated. Facilitated CT scanning by a measure that we call code laparotomy. So if we call code laparotomy to radiology, then we'll get a scan within an hour. It'll be prioritised.
There's no bitching and moaning. It's kind of like, yes.
Waiting for the scanner. It's like the stroke alert.
Correct. There's early risk assessment, including blood gases and a lactate. There is prioritisation of getting the patients to theatre in a timely fashion. So they are categorised according to their deemed urgency for theatre, be it within 6 hours or 6 to 18 hours or longer than 18 hours. But they then get to theatre in that time. Yeah. And our emergency theatre is run strictly on clinical priority. So we've devolved the responsibility for ordering the cases in the emergency theatre to the surgeons, providing they can agree based on clinical priority. And if they can't agree, the anaesthetist will decide and take things over. But essentially, we do prioritise these cases, so they do get to theatre. The ones that need to be there in 2 hours are there, or within 4 hours are there, usually within 2 hours, and they get their surgery quickly. The involvement of a senior anaesthetist and a senior surgeon in surgery. So we're better, probably about 85% consultant surgeon involvement in the surgery, which is perhaps a reflection of the changes in training in the surgical registrars, and probably about 70% anaesthetic consultants, but we do have quite senior registrars. And then, as I say, admission of all of the patients to intensive care. So NELA suggests admission to critical care of all patients with a predicted mortality above 5%. And we decided we'd admit everybody. Yeah. And so we've stuck to that. Also, I didn't mention goal-directed fluid therapy in theatre as well. So I've probably mentioned more than 6 elements, but I think those are incorporated in those
key bits
those
of it.
elements.
Crack on with it, get in the theatre with the right people, right time. Use goal-directed fluid therapy, early antibiotic administration, everyone gets intensive care. Sure. Now, I kind of think a lot of people are thinking, hang on a second, I'm having an emergency laparotomy. Surely that's what you always do anyway. Is that
I wasn't thinking that, actually, but you're right. I bet our patients think that.
That's what I'm saying.
I'm sure they think that.
Is that so? The United States of America, surely the country that spends more money on healthcare than anyone else in the world, does this to everyone, surely.
I think the everybody admitted to ICU piece is something that would challenge us for beds. Our surgical, I work in a 24-bed dedicated surgical ICU.
Well, time out for a second. How many beds you got at Duke?
1,000. We have 1,000 beds at Duke.
How many ICU beds do you have at Duke?
150.
Okay. You got 600 beds, and
correct.
And how many ITU beds?
Critical care beds, we've got 15. ITU beds, we've probably got 7.
Okay, so Paul, I think you need to go back and work that one out, buddy. Yeah.
So
get rid of some of those people who don't need to be there and bring in the ones that do need to be there.
We do have a range of patients I think we all question if need to be there. Often we can't get them out because of floor bed lack. We lack floor beds to send them or nurses to send them to. But I don't believe, and I'm not an acute care surgeon, I suppose, but I see lots of their patients work very closely with them and respect them immensely. They work very hard.
Yes.
It makes me wonder if the acute care surgery model that we work with in the United States, I don't know if you work with the same, where anything that walks in the door is cared for by a single acute care surgeon, whether it's, whatever laparotomy it may be, any kind of emergent surgical need is dealt with by one surgeon. That team may have 50, 70, 80 patients on their service at a given time. It's to alleviate the other general surgeons from having to take call and operate on cases they don't, if you're an endocrine surgeon trying to do an emergency laparotomy, that's not necessarily the person you want doing your emergency laparotomy for your perfed colon. But it creates this really brutal burden of call and a very large patient list that I have immense respect for how hard they work.
Because Carol Peden, when she spoke to us recently, she shared with the fact that having now moved to the USA, she looked closely at the USA data that's available as well.
Yeah.
And to reassure the audience that the results from the UK are transferable, the emergency laparotomy mortality rates are very similar in the USA as where we were, if you see what I mean.
Oh, where you were. Yes. So it's very transferable.
So it's not as though it's a crazy story. There's very few people reporting rates down in single figures.
Yeah, that's
We've
impressive.
sustained that for at least 18 months now, I think.
Okay.
And what's interesting is that as we've re-engaged with the bundle, so our run charts of activity, the variation from month to month has dramatically decreased. So not only has our performance improved, our engagement with the elements of each bundle, but the variation from month to month, which there's always a natural variation, but that has decreased quite significantly. And I think one of the ways we look at it, one of the run charts that Leslie Jordan, who's one of my colleagues, has produced, is a number of cases between deaths. So number of successful laparotomies, and we've increased the number of successful laparotomies we do between deaths from 6 to 13 during that time.
That's a neat number.
Which is quite a nice way of looking at it as well.
What do you think the key component of that is? Like, in ERAS we say the same, right? What is the thing that's really making the difference? And
well, that's the really big question. I think So I'm now convinced, given that we've done it twice and fallen in a hole in the middle, that this bundle works. And the bundle is essentially the same on both occasions.
Yeah.
And interrupt there for a second. I'm kind of guessing if someone was signing on the dotted line, they'd say, "That sounds jolly sensible, Doc. Please do that for me."
Yeah, you'd think.
I don't want you to drop any one of those. It sounds like they sound good.
Well, aside from resource utilization, I mean, 16 ICU beds, and maybe, I don't know how many admissions you take a night on your acute care surgery service.
So, Paul, I'm interrupt. Our experience, if you get it right first time, you use fewer beds. If you send them to the
that
floor,
sounds sensible to me for sure.
You send
I just
them to
wonder
the
if you
floor
have enough beds to send them to.
Well, if you send them to the floor and readmit them,
well, it's a disaster.
Our IT is pretty full. We don't have many beds, but it's fairly full.
Yeah.
It's mainly medical intensive care, so that's medicine as well. And we're 70% occupied by medical patients.
What do you do when the ICU is full and the emergency laparotomy comes in?
Great question.
Yeah, we try and admit them. So we'll, as anybody who practices critical care in the UK will know, ITU is often full, and you have to balance the needs of certain patients, perhaps a patient who's close to being ready for discharge from critical care against the one who needs admission. We do have a formal policy whereby if there really is no ITU bed, then we will keep them in recovery for 6 hours. They will go through a pathway in that during that time during the 6 hours, which will include regular blood gases. So essentially it's critical care at a distance. And after 6 hours, they'll be reviewed by a senior clinician who will then make the decision as to whether they remain an intensive care patient or whether they then default to go to the ward.
Your recovery room becomes your default, your pop-off.
But we are... And I think the element of getting patients to ITU, you say that all these laparotomies, of course they go to ITU, but I think unless you really look at it, unless you make it a policy, we had to make it a decision that was actually agreed at director level, that we increased the number of intensive care beds by 2. This was part of the bid for that, and had to get all the intensive care consultants on board to do it. I don't know which element makes the difference, and
maybe it's all of them.
My view has been, the bundle makes a difference, so let's maintain them. And we actually have equipoise in the department about certain things like goal-directed fluid therapy. So I thought it was the answer is to carry on with the bundle, embed it, get everything right, get the culture right, and then you can start chipping away. Well, let's see what happens when one's taken away. And that's actually where this study Floella comes in.
Yes.
So Floella is a study looking at goal-directed fluid versus standard care in emergency laparotomy. Okay. And we're now taking part of that. So effectively we have this bundle. Our normal practice is goal-directed fluid therapy. And in half our patients now, they're being randomised to not receiving it.
Within the bundle, then?
Yeah.
That's FLOELA.
Yes.
And you can look that up online and find it. It's aiming for about 7,000 or so.
I think it's 8,000, but 8,000, yeah.
That's Mark Edwards from Southampton.
Correct.
And Rupert Pearce, so I can just see over your shoulder, who runs our Centre for perioperative research, which is great. So that's patients recruited into the thousands in that, aren't they?
Correct. I think it's closing in on 2,000, I think.
Wow.
So, 1,000.
So if I was wearing a government payer's hat, I'd sort of turn around and say, look, guys, that all sounds pretty sensible. That all sounds jolly affordable. Couldn't you stress about something else? If you can get everyone to do the 6 elements, you're talking about tiny marginal costs compared to the misery and the cost of keeping someone in intensive care for a day extra.
The affordability is an interesting question, Monty, because we looked at 3 cohorts of patients that we had, going back to this ELQUIC study, the first intervention we did, and we looked at our patients before ELQUIC, during ELQUIC and after ELQUIC, where we had these different mortalities, about 12, 7, 10 and 5%. And we looked at the cost per life saved. So there were more patients going to intensive care, but we looked at, in simple terms, time spent in theatre, time on wards, time in intensive care. And essentially the cost per life saved was identical, even including the bundle. So it's a cost neutral thing to do.
Yeah, so you are keeping them out of the complications and the long stairs and the readmits. Yeah, so you must be.
So everyone should get on with it, shouldn't they, for now, until we...
And then you should add early feeding as your last piece,
right? There we go.
Which clearly we know works at ERAS. That's one of the 2 driving features, if you believe some of the
everybody gets, as part of one of the bundle, one of the add-on bundles that we've added, everybody gets routinely, whether they're, certainly for all the open surgery, it's harder for the laparoscopic surgery, they get nasogastric and nasojejunal tubes, so they can be early fed.
That's good.
Anything else, Paul, before we let
it's brilliant. That's interesting. It'd be interesting for me to ask I'm very close to my acute care surgeons and what they think of that, what they would say, gosh, if you took every emergent laparotomy that came through and said, we're going to put this person in the unit, I bet we do admit a substantial percentage, but I don't think it's all.
They don't have to stay for that. When it goes well, they don't have to stay for that long, do they?
No, probably not, right?
No, sometimes you'll say, why are we sending this patient there?
Yeah.
In the morning, maybe half of them have got a reason why you want to keep them another 24 hours, and half of them don't, and they can go. But usually we can't get them out straight away because the wards are full. But the other, if I can just very briefly mention, the other thing we've been doing, which we're just really looking around the edges, the whole troponin story.
Yes.
So the elevated troponin, we've done a little bit of work on looking at troponins in these emergency patients, and that's an area that hasn't really been explored in any great detail. It's been looked at, obviously, in Vision and other studies in great detail in the elective cases, but we decided that, given the high-risk nature of this group, that we would do troponins each morning for the first, on the bloods before they had their surgery, and then on the next 3 days. And we've been looking at how that's changed our management of the patients. So it's changed our investigations in about 1 in 17 patients in our first cohort. It meant that they got additional either cardiological investigations or cardiac interventions, most of which were... So most of these patients were having normal ECGs, but a significant number had elevated troponins by more than 20%.
And most of them are septic, aren't they? does that make it difficult to...
What's the comorbidity you're reducing too? Yeah, in your intervention. But yeah, the sepsis would influence that some, eh?
All we've looked at so far, and it's very preliminary work, it's simply observational, is we looked at the data in elective cases and thought, well, ECGs don't seem to be very sensitive. Mm-hmm. These patients are high risk. Mm-hmm. Another piece of work we've looked at suggested that although the common complications when we looked at PROMS data from emergency laparotomies, we identified that lots of patients were getting gastrointestinal and respiratory problems post-operatively, but the factors that were most associated with mortality were cardiovascular complications.
Interesting.
So those were less frequent, but more associated with mortality.
Yeah, for sure.
And we put our heads together and we started looking at troponins. And we don't really know where it's going, but about 20% of the patients had elevated troponins post-op. Not dramatically often, but we used a 20% increase from their preoperative value, or 20% above upper limit of reference range, and used that to trigger echoes when they wouldn't have had echoes, or a consult to a cardiologist.
Brilliant. Well, time's being called on us.
That's great.
Paul, thank you very much for staying. Tim, thank you very much for your generosity and joining us again. We'll hope to interview again soon.
I know only two things about Duke. I'll tell Paul. Two things.
You knew two jokes.
I'm afraid. Yeah, I'm afraid.
Two things about Duke. So I've played rugby there.
Is that right?
Oh, well, that puts you in a very small category.
And TJ Gann, who may have been there before.
Yes, he was.
So he was in my maths class at high school.
Say hi to TJ.
You go way back, yeah.
He's gone to Stanley Brook now.
Yeah, I know
he is, but someone I've known a long time. Yeah.
Two great pieces of information. Well, gentlemen, thank you very much indeed.
It's a pleasure.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.